So good morning and welcome to Chicago. My name is Eric Armbrecht. I'm the chair of the Midwest CEPAC. I'm a professor at St. Louis University. So I think we're going to go ahead and get started with today's program. I'm going to ask all the members of the Midwest CEPAC to introduce themselves and declare any potential conflicts of interest that they might have regarding the first topic for today, regarding prostate cancer. And we've sort of met as a group, and they've met all of the basic requirements in terms of conflicts of interest for ICER. But if they have anything addition that they'd like to add or anything specific to prostate cancer, I'd like for them to declare that as they make their introductions going around the table. First, Timothy.
Hi and welcome. My name is Timothy Wilt. I'm a general internist and health services researcher at the Minneapolis VA and the University of Minnesota. I have some disclosures with regard to prostate cancer. I have written articles and received federal funding related to disease detection and treatment, primarily in localized prostate cancer, but have not done any research, been funded for work on non-metastatic castrate-resistant or these drugs.
Hi, Stacy Doucette-Zena. I'm an associate professor of health policy and an Ingram Associate Professor of Cancer Research at Vanderbilt University School of Medicine. I don't have any financial conflicts of interest related to prostate cancer.
Thank you. Don Casey, an internist by professional background. I am the Chief of Clinical Affairs of MedDecision, which is a population health technology platform company. I'm also on the faculty here at Rush, right next door. Welcome to Chicago. And Jefferson College of Population Health, and I have no disclosures.
My name is Aaron Carroll. I'm a professor of pediatrics and health services researcher at Indiana University School of Medicine, and I have no conflict of interest related to this topic.
Good morning, everyone. My name is Reem Mustafa. I'm an associate professor in internal medicine and Division of Nephrology and Hypertension, University of Kansas Medical Center, and I'm the director of Outcomes and Implementation Research at the Kidney Institute, and I have no financial conflict of interest.
I'm Harold Pollack. I'm a professor at the University of Chicago. I'm a public health researcher. I have no financial conflicts. My father is in treatment for prostate cancer, doing very well, but no financial conflicts.
Ryan Barker. I'm the Vice President of Health Policy with the Missouri Foundation for Health, and I have no conflicts of interest.
My name is Jill Johnson, and I am a professor at the College of Pharmacy at the University of Arkansas for Medical Sciences, and I have no conflicts.
Hello, Stuart Winston. I'm a cardiac electrophysiologist in a large multi-specialty group in Ann Arbor, Michigan. I have no financial disclosures.
I'm Greg Kerfman, Deputy Editor of JAMA here in Chicago, cardiologist by training, no conflicts.
Thank you, everybody. And once again, my name is Eric Armbrecht. I have no conflicts of interest on this topic either. Special thanks, and just a reminder for everybody on the panel as we ask questions or have comments today to use the microphones. That was a special request was made because we need to make sure that it's the audio is properly broadcast through the streaming video. And welcome to all of our folks that might be joining online or those that will be watching later on a recording. I'd like to introduce our leader for today, Steve Pearson, President of ICER, who will be essentially facilitating today's meeting, and we're glad to introduce you today. Thanks.
Thank you. Good morning, everybody.
There we go. Well, welcome again, and now that you can hear me. Thank you, Eric, and welcome to the CEPAC and to the guests in the audience here and watching via webinar. So a brief introduction to today's meeting, which will include an agenda and a little bit of background on the methods and the process through which we will debate these issues today. So we're here this morning for several reasons. One is because prostate cancer is a very, very important condition. In terms of disclosure, my father and grandfather developed prostate cancer at a relatively young age, And many, many people have prostate cancer at some degree of separation from their immediate family. And for men with prostate cancer, there are two landmarks of really significant changes. We hear this from patients, that there are two significant landmarks: becoming castrate-resistant and then developing metastatic disease. And we have a quote from one patient that sent a comment to us who said, "Men are angry, frustrated, frightened, and often depressed when they reach these points. As their disease progresses, they come to the realization that all available treatments only work for a very limited period before resistance develops and the cancer progresses. Also, at that point, many of them have gone through enough treatments to know that every one of them will have side effects and a likely diminution in their quality of life." So we're here because we have innovation to help patients in these situations. And anytime we have new treatments, they often raise questions about their appropriate use and about their cost, especially for a condition that is widely prevalent like prostate cancer. So in a 2017 survey report from the cancer support community, more than 50% of respondents reported having monthly prostate cancer-related out-of-pocket costs themselves of more than $100, with 25% of respondents reporting over $500 in out-of-pocket costs per month. So it's not just costs to the system, it's also costs for individual patients that are part of what people wrestle with when there's new innovation that can help them. So we believe that that's part of the reason that there's a need, a benefit from having an objective, independent evaluation, and importantly, public discussion of the evidence on effectiveness and value to help guide the system that will be ultimately in ways that will help patients maintain innovation and sustain the affordability of the whole health system. So you've been introduced to the members of the Midwest Comparative Effectiveness Public Advisory Council, or CEPAC. The academic, if you will, background work for this was performed by the Institute for Clinical and Economic Review, or ICER. So let me just introduce ICER briefly and the methods that went into the report. So first, in terms of ICER's status, as an independent not-for-profit, we keep a pie chart of our overall funding on our website and update it regularly. For 2018, as you can see, approximately 78% of the funding, and all of the funding for this work comes from nonprofit foundations, the chief of which are the Laura and John Arnold Foundation, the California Healthcare Foundation, and the Blue Shield of California Foundation. We have a separate policy summit program that we run with leaders from the manufacturer community and from payers and PBMs, from which we take direct contributions for that program in essentially equal proportion between the payer and the innovative or the life science community. And we have a small residual state contract. So how this report was developed for therapies on prostate cancer is similar or the same process that we take for all of our work. We start with a very intensive scoping phase in which we reach out for guidance from patients, patient groups, clinical experts, the manufacturers in this area, to basically really learn the landscape and to understand where the nuances in the evidence, the questions, the controversies, and how the patients view value from their perspective, what outcomes mean the most to them. And we just try to work really hard to make sure we learn what we don't know coming into this and to get sorted. So then we do plow ahead and we do a systematic review of the literature through an internal ICER staff review. We also often collaborate with outside academic cost-effectiveness modelers. Today's work was done by researchers at the University of Washington. We go through formal periods of public comment and revision, in addition to talking to patient groups and manufacturers throughout the process. And this report also underwent expert report review from two clinical experts, Jerry Ritchie at the Brigham and Women's Hospital and Matthew Smith at the Mass General Hospital. Neither of these clinical experts should be assumed to approve of the report in any specific way, but we appreciated their input and their guidance and editing suggestions. So ultimately, how is the evidence that we gather from all these different sources structured to support today's report and the meeting? Well, from a kind of a conceptual picture, Our reports are framed to help support evidence and discussion that will support a specific goal, which is to achieve sustainable access to high-value care for all patients. And we believe that there are two different elements that are important in getting us to that goal. One is for the health community to think about long-term value for money for new interventions, and the other is to think about its potential impact on short-term affordability, because sometimes those two aspects can be in tension. Within the key idea of long-term value for money, we identify four conceptual categories. And again, this is the way that our report and in some ways the meeting itself is structured. There's an important focus on the clinical evidence on comparative clinical effectiveness, using the best evidence we have from clinical trials, from patient-reported outcomes, from observational data, all comes into that part of it. We do an incremental cost-effectiveness analysis that you'll hear about. Then we also want to keep our eye on what we call potential other benefits or disadvantages and contextual considerations. These are aspects of value, long-term value, that may not be captured directly by the clinical evidence or other sources of evidence. But we'll talk about what they are as part of the meeting and as part of the voting, and they become an important part of the guidance that payers and others take from our work. For short-term affordability, we do an analysis of the potential budget impact of new innovations so that, again, if there is a potential tension between the short-term ability of the budgets of the health system to afford new innovation, even if it provides a good long-term value, we can highlight that and alert policymakers that they may need to really focus on that tension to make sure that access to patients isn't the thing that suffers. So the agenda for today includes two topics. This one will be handled in the morning agenda, where there will be an hour's presentation of summary of the evidence and discussion from the CEPAC. Then we will have a section for manufacturer public comments. There are opportunities for public comment, but no one registered for those today, so we'll move directly to the manufacturer comments. Following which there will be a session on the voting and further deliberation on the information, and reflections from experts and the New England CEPAC panel to close out the morning. Now, before I hand it back over to the chair and to the presentation of the evidence, I would like to have a chance to introduce the patient representative and clinical expert who are available this morning and throughout the day to help serve as a resource to the CEPAC and to offer their perspectives. Would you please introduce yourselves briefly and also state whether you have any specific conflicts of interest for this topic?
Good morning, everyone. My name is Russell Schmolowitz. I'm an assistant professor at the University of Chicago, and I'm the director of the genitourinary oncology program there. So I'm a medical oncologist, and my practice focuses on advanced prostate cancer. I also do both clinical and translational basic science on hormonal therapies, predominantly in prostate cancer. It's important from a conflict of interest standpoint that I see a lot of patients with this disease, so I'm emotionally conflicted. But in all truth, financially, I have served as a consultant for multiple companies that manufacture drugs in this space, including Janssen, Pfizer, and Astellas, all for less than $5,000 each, but it's important to disclose those conflicts.
Thank you very much. Mr. Nowak?
Good morning, everyone. My name is Joel Nowak, and I am a survivor of 5 primary cancers. I have prostate cancer, and I have been metastatic now for 12 years, but I consider myself healthy. I work currently as the founder and the CEO of an organization called Cancer ABCs. We work with people and help them be able to thrive despite having cancer. Prior to my 2 years after having formed this organization, I worked with another organization, MaleCare, where I developed their entire programs for men with metastatic prostate cancer. I'm very involved, speak to hundreds of men who are metastatic and who are not metastatic, but my area of interest and expertise really is in the metastatic phase. excuse me. As a financial disclosure, I do sometimes consult with pharmaceutical companies, particularly in the area of development of clinical trials. And I am working currently with Pfizer, who does have a drug here, so I want to disclose that. It's all under $5,000.
Thank you very much, gentlemen. Thank you very much for being here. And CPAC, you have them at your disposal during the rest of the morning. With that, let me introduce ICER's Chief Medical Officer, Dr. David Rind, who will present a summary of the evidence on comparative clinical effectiveness.
Good morning, everyone. I wanted to acknowledge Patty Sinnott, who's here, and Aksa Magal, who isn't, who were key review members for ICER. We have no conflicts of interest relevant to this report to disclose. Prostate cancer. It's the most common cancer in men, not counting non-melanoma skin cancer, and it's the second most common cause of cancer death after lung cancer in men in the United States. The estimates for 2018 are that there'll be 165,000 new cases of prostate cancer and 30,000 deaths. There's disproportionate effects in black men. The incidence is 60% higher. Mortality is 110% higher. The language and terminology of how we're discussing things today is tricky, and I'm going to take us through some of that. Prostate cancers typically respond to androgens in some way. Androgen deprivation therapy, ADT, involves medical or surgical castration. In the United States, almost always medical castration, where medicines are used to drive testosterone and other androgen levels very low. It's used in a number of clinical settings for prostate cancer. And prostate cancers are said to be castration sensitive in two different settings. One, when they have never been treated with ADT, they're assumed to be castration sensitive, and the other where they're being treated with ADT and still responding, and they're said to be castration sensitive. So what's castration resistant? If you have clinical, radiographic, or biochemical progression, despite ADT that has achieved low levels of testosterone, it's said that the prostate cancer is now castration resistant. Often, the first indication of this is a rise in the PSA, prostate-specific antigen, the marker that's used for screening, but is also very helpful in men who actually have prostate cancer. In men with this, if imaging is done and they're found to have metastases on conventional imaging, things like CT or bone scans, this is said to be metastatic castration-resistant prostate cancer, mCRPC. Randomized trials in that setting have shown that anti-androgen therapy, distinct from ADT, improves survival. That's been shown with two drugs that have indications for this. One is abiraterone acetate, which is an androgen biosynthesis inhibitor. Another is enzalutamide, which is an androgen receptor inhibitor. If the PSA is going up despite ADT, but you don't see metastases on conventional imaging, you're said to have non-metastatic castration-resistant prostate cancer. However, the PSA is going up. Almost certainly, this is an earlier stage of metastatic disease, and if you used more advanced imaging techniques, you might find the metastases. So this is a continuum. In this setting, the rate of rise of PSA predicts risk. We talk about that in terms of PSA doubling times. So if the doubling time is lower, 2 months is worse than 6 months is worse than a year. Lower numbers are worse for PSA doubling time, higher risk. In the past, the recommendations for what to do in this setting were to continue androgen deprivation therapy and keep looking for metastases on conventional imaging, because if you found them, now you had something to do. You were going to add anti-androgens. What the question we're looking at today is about what the benefits are of starting that anti-androgen therapy earlier before metastases are seen on conventional imaging. As part of this report, as Steve was discussing, we get insights from patients and patient groups. We heard not surprisingly, given the severity of this disease, about the effects of the risks of morbidity and mortality, both on patients and patients' families. We heard about the psychological effect on the sense of self of prostate cancer, but also about imagine having non-metastatic, knowing your PSA is going up, and being told all we really can do is wait. And we heard about the psychological benefits of having something to do, a treatment. In medicine, we know that that's not always a good thing, but it does have psychological effects that there's something to do. We heard about the sense of failure when PSA rises after burdensome therapies. Men will have often undergone radical prostatectomy with all the complications related to that. They'll have been on hormone therapies with their side effects, and now the PSA is rising, suggesting that the therapy is failing. We heard about the variable tolerability of treatments, that patients really aren't all the same on this, but that fatigue is a common substantial side effect of these therapies. And we heard about financial toxicities, including financial toxicities that led some patient groups tell us about patients they knew that had chosen not to get therapy because of the financial toxicities to their families. So the scope of this review, we're talking about men with non-metastatic castration-resistant prostate cancer. The intervention is adding one of the following anti-androgen therapies to androgen deprivation therapy, apalutamide, enzalutamide, or abiraterone acetate plus prednisone. Abiraterone acetate has effects on the adrenals, and so you need to give a corticosteroid with it. And the comparison is continuing therapy with ADT without anti-androgen therapy until metastasis develops. The evidence base is really from 3 trials and studies. For apalutamide, we have the SPARTAN randomized trial, which had about 1,200 men, PSA doubling times less than 10 months. Again, lower is worse. Less than 6 months is often viewed as an important cutoff as well. Enzalutamide was studied in the PROSPER randomized trial, about 1,400 men, similar PSA doubling time. And then for abiraterone acetate, we have a single-arm study, the IMAGINE study, in 131 men, could either have a PSA above 10 or a PSA doubling time below 10 months. And we have trials of abiraterone acetate in metastatic castration-resistant prostate cancer. So what did the randomized trial show? For apalutamide in SPARTAN, we have on overall survival a hazard ratio of 0.7. You can see that the upper end of the confidence interval is 1.04, so not quite statistically significant. The primary outcome was metastasis-free survival, or time to the development of metastasis or death. And for that, there's a dramatic improvement, hazard ratio of 0.28. Quality of life was looked at in SPARTAN, and in both arms, both in the placebo arm and in the apalutamide arm, quality of life was stable. For enzalutamide, we have a hazard ratio of 0.8 on overall survival. Again, not quite statistically significant. We have the outcome of metastasis-free survival, again, the primary outcome in the trials, with a hazard ratio almost identical to that in SPARTAN. And the quality of life in PROSPER looked between the 2 arms, and it was similar between the placebo arm and the enzalutamide arm. Fatigue is common with these therapies, 30 to 40%. Falls and fractures turns out to be an issue with these drugs. Both with apalutamide and enzalutamide, you can see those percentages and that they're higher than the numbers in parentheses, which are the placebo percentages, so 16 versus 9% for falls, 12% versus 7% for fractures. Enzalutamide, 11% versus 4% for falls, 10% versus 5% for fractures. Ischemic heart disease. This was an uncommon serious event in SPARTAN and PROSPER, but the FDA pooled analyses of 3 randomized trials of enzalutamide and found more serious ischemic heart disease events with enzalutamide than with placebo, 1.2 versus 0.5%, and this resulted in a warning on the label of enzalutamide for ischemic heart disease. What about abiraterone acetate? So in metastatic castration-resistant prostate cancer without prior chemotherapy, For survival hazard ratio, you can see with abiraterone acetate versus placebo, it was 0.81. With enzalutamide, very similar number of 0.77 versus placebo. Those aren't comparing those drugs to each other, those are each against placebo. With prior chemotherapy, similarly, hazard ratio 0.65 for abiraterone acetate, 0.66 for enzalutamide, very similar. We have single-arm studies in non-metastatic. We have the IMAGINE trial looking at median time to PSA progression. The reason I'm picking that outcome is because it was available for both trials, not because it's necessarily the best outcome. And for abiraterone acetate, it was 28.7 months. For apalutamide, 24 months. So there, remember, longer would be better for time to PSA progression, so you can see that the abiraterone acetate number is similar to and certainly not worse than apalutamide in the single-arm studies. However, and you might conclude from all that, well, abiraterone acetate looks like it's probably just as good, and it may be just as good. However, not all data suggest equivalence. That number that I just showed you of the 28.7 months from IMAGINE, if we compare that to the similar numbers from the randomized trials for apalutamide, the median time wasn't reached in SPARTAN, but was certainly longer than 32 months, looking at what was shown. And in PROSPER was 37.2 months. So not looking as good as the numbers in the randomized trials. A little bit hard to know what to do with the single-arm trial number versus single-arm study versus the randomized trials, but it's an issue in terms of our certainty that we could really say these drugs are equal to each other without better study of abiraterone. One reason this comes up is that abiraterone acetate is going off patent, and so it's not the drug that was studied in this new setting. There wasn't an incentive to do that. There is, in Japan, a randomized trial called the ENABLE trial, which is looking at both non-metastatic and metastatic castration-resistant prostate cancer and randomizing patients to enzalutamide or abiraterone acetate, but we have no results from that at this point. It's not a manufacturer-conducted trial, and I have nothing useful to tell you about it for this meeting, but maybe down the road we'll learn something. What don't we know? The overall survival results are immature. Metastasis-free survival is a surrogate. Patients aren't symptomatic necessarily when they progress to metastasis, and so they're not having symptoms with this, and if we were just improving MFS, that wouldn't be sufficient. We'd want to be doing something related to symptoms or something related to survival. SPARTAN and PROSPER only looked at PSA doubling times of 10 months or less, but their approved indications by the FDA is broad. It's all men with non-metastatic castration-resistant prostate cancer, no matter what the doubling time. Black men, remember, are at increased risk for morbidity and mortality from prostate cancer. They were underrepresented in SPARTAN and PROSPER. And in the subgroup in SPARTAN, metastasis-free survival hazard ratio was 0.63 compared to the 0.28 overall for all men. There were wide confidence intervals on that. I don't want to imply that that proves that it has a differential effect in black men, but we certainly haven't proven that it has the same effect in black men. And the data are inadequate to compare the anti-androgens to each other, something we'd like to be able to do. The definition of metastasis-free survival was slightly different in SPARTAN and PROSPER. And in any case where we're looking at survival numbers and we're talking about such an important outcome as survival, people would care about relatively small differences. It's very hard to tell without head-to-head trials. So how did we rate the evidence? We felt that we had high certainty that apalutamide provides a benefit compared to waiting. We felt that we had high certainty that enzalutamide provides a benefit compared to waiting. And we felt that we had high certainty of at least a small benefit with abiraterone acetate compared to waiting, and that the benefit could be as large, B+, so it could go all the way up as high, but that we couldn't know that, and we have less certainty about the upper ends of this. We felt that we had insufficient evidence to compare any of these drugs to the other drugs. Potential other benefits and contextual considerations. Again, this is a disease that disproportionately affects black men. We felt that there was a potential to reduce health disparities. As mentioned, we heard from patient groups and clinical experts that there may be psychological benefits to having having a therapy rather than just waiting. That's not the sort of thing that shows up in a clinical trial or in an economic analysis. And in the other direction, in the absence of more mature survival data, there's significant uncertainty about the survival benefit. We think the survival benefit is there, but whether it's as good as the early numbers from the randomized trial, there's still wide confidence intervals with substantial uncertainty. We received some public comments. One was about that B+ rating for abiraterone acetate, feeling that it hadn't been adequately explained. Our thoughts on abiraterone acetate are really twofold. One is it looks a lot like the other drugs in metastatic castration-resistant prostate cancer, and this is a continuum. And so there's a lot of reason to expect that this drug will have efficacy in non-metastatic, given that it has efficacy in metastatic and two other drugs that are anti-androgens have efficacy in non-metastatic. So that's part of what pushed us in that direction. And the other part is that the IMAGINE study, even uncontrolled, really looks like benefit is happening there of a sort that suggests that there's at least a small benefit with abiraterone acetate. And so we felt that we had at least high certainty of a small benefit, even though we couldn't really say how large the benefit was. That's how we got to B+. We got the comment that metastasis-free survival has been shown to be a valid surrogate for overall survival. This is a little bit tricky because some of that evidence doesn't really come from this particular setting where you're treating earlier rather than later. There has been at least one analysis that does come out of this space that suggests that it is a valid surrogate. I'll find that more convincing once we have better overall survival data so that that analysis can be done more convincingly. But there are some data on this. We got a couple of comments that the ICER report didn't talk enough about the real-world evidence and patient-reported outcomes, even though ICER says we focus on those things. I think this, to some extent, misses the role of ICER. We don't generate evidence. We report on evidence. If there are concerns that there isn't real-world evidence and enough patient-reported outcomes, people need to speak to the researchers and the manufacturers. We would love to have more of that to put in our report, but we can only put in the report the evidence that's out there. Finally, after the public comment period had ended, we received an email from one of the world experts in prostate cancer concerned that we were being overly credulous about the survival benefit given the lack of statistical significance, wide confidence intervals, and that he wasn't sure yet about the overall survival benefit. And so I wanted to communicate that and how, again, we felt we were thinking about the patient important outcome benefits of apalutamide and enzalutamide. And in this case, we felt that the SPARTAN trial and the PROSPER trial reinforced our belief in each other, that these were very similar drugs in very similar populations, and that you could imagine meta-analyzing them, even though we chose not to do so formally. But here is an informal combination of those, and you can see that with that we get a pooled estimate of a hazard ratio of 0.76 with an upper limit of 0.97. And so if p-values of 0.05 or hazard ratios, or confidence intervals hitting 1 matter to you on statistical significance, this would be statistically significant. That said, if you took the belief that the upper end of the confidence interval is a credible range, if it were only 0.97, that probably wouldn't be clinically significant. However, we also have for apalutamide an analysis of time to symptomatic progression, which showed a clear benefit on times to symptomatic progression for that drug. The analysis doesn't show up for enzalutamide. And so there's a patient-important outcome, even if it's not overall survival. And we felt, again, that it was reasonable to apply the similarity of these drugs to both drugs. And so taking that all into account, we felt that we had high confidence that there were substantial benefits to earlier treatment. I mention this, though, to you because we certainly got pushback from somebody who would be viewed as having a right to push back on this and think about it. I still come down on the side of believing that there are substantial benefits and that our grade of A is appropriate, but I can understand where somebody might come and think that a B+ was more appropriate for those drugs. Thank you. And I don't know if people have questions now or...
First, we'll go to the CPAC panel. Do you have questions? Any questions? Yeah, please, Stacy.
So you mentioned a psychological benefit of having a therapy available, and I'm just curious, in the setting where you start the treatment early and then someone progresses, is there anything additional that would be recommended to be done later now that you've started those therapies earlier, and maybe sort of the psychological impact of progressing and not having a next step?
So it's a fair question. I think depending upon whether chemotherapy has been administered at that point, it might be given. I don't know if you...
So it's a great question, and I would say that we as clinicians like to have a bullet in our holster, right? Like, it's sort of comforting to know that we have a drug that we can give to patients down the road. That doesn't mean it's the right thing to do to hold on to that bullet. The question specifically is what happens next, essentially. So if a patient progresses on either of these drugs, or on abiraterone for that matter, there's very good evidence that they are unlikely to benefit from the other one or from another drug in the same similar class. They're very unlikely to benefit for really more than a few months. 3 or 4 months would be the median progression on the second agent. So what you are left with essentially is cytotoxic chemotherapy, which isn't as bad as it sounds, but it's chemotherapy nonetheless, or investigational agents with some exceptions. That's the same options that you would have, by the way, if you waited until metastatic disease, then started abiraterone or enzalutamide, then progressed 18 months later or so. Those would be the same sort of decisions and discussions.
Yeah, I will say that many men have difficulty sitting around and doing nothing, or what they perceive as doing nothing. So from a psychological standpoint, many men find it a lot more difficult not to do anything. Now, does that necessarily mean that it's the best medical direction? No. But certainly from the psychological standpoint, yes, the vast number of men feel they need to do something.
Don, go ahead.
Thank you. 2 questions that are related. One is falls and fractures. The question in my mind is that are there fractures that occur without falls? And then, or are you talking about falls with fracture? In other words, do fractures occur independent from falls? And the second question is, are the patterns of the causes of death different from other populations of men dying with prostate cancer, and in particular, are any of these related to falls and or fractures?
Can I add to that, because my questions
please
go along with the falls and fractures? I don't. It may be anecdotal, but is there any evidence? Is the increased fatigue related to the falls? And do these is there any evidence these drugs actually are doing something to the bone density that makes it more likely that there are fractures when there are falls, or is it just older because folks are older when this?
So I think on the fractures side, testosterone does affect bone, and so I think there's a thought that people understand what's going on there. On the falls side, my sense is that when the SPARTAN data came out, people weren't entirely sure what to make of that, and then it appeared again in PROSPER, and the sense is that it's real, whether that's directly related to fatigue, whether there's something else going on, it seems to be real. The data weren't reported in such a way that I have a sense of how often fractures are occurring independent of falls. I don't know if you have any feel for this.
Joel, do you want to?
Yeah,
add some color to that.
it's a complex physiology, and we don't have a ton of data from these studies to fall back on. I'd say that yes, these agents do cause a diminution in bone health, so there can be fractures without falls. Now, that's uncommon in a trial like this. So there are other trials that they do surveillance, X-rays to look for compression fractures and the like. That they didn't do that on this study. So there may have been fractures that were picked up anecdotally on their routine surveillance imaging, but we don't have granularity on that data. We, as a best practice, do check bone density on all patients who are on hormone therapy, and for patients who have a decreased bone health, we give bone strengtheners, which decreases the chance of skeletal-related events or fractures and things like that. The falls are real and I think multifaceted. So one, there's sarcopenia, so a decrease in muscle mass associated with this class of agents, and that's been well described, not in this trial, but in many others in this class of agents. So men lose muscle mass and they're more prone to falls because they don't have the core strength that they once had. Fatigue is a nebulous term. Surely that is related to sarcopenia, but might not be the same thing, and so men just are sort of feeling tired. Whether that leads to falls, I'm not sure. And there's also many men, and you can comment, will describe a sort of a decrease, a fogginess of thought that comes with these types of medicines. So patients perhaps might be more prone to be less aware of their surroundings. In terms of how often are they clinically meaningful or resultant in death, I would say it's pretty very rare and unlikely to be the case. That they're, life-threatening falls or life-threatening fractures. That doesn't mean they're not quality of life-threatening.
I mean, I want to make a comment on that. I mean, I know that bone strengthening medications are used fairly regularly, but there is a precaution that one needs to remember. I think that long-term use, certainly of zoledronic acid, does encourage significant and major femur fractures, which can, in fact, be very, can definitely, diminish the quality of life of a man. These are really significant fractures. So there needs to be caution in the use of these drugs, and they need to be it needs to be rethought about how long it's appropriate to use them. I do think that brain fog, or what is sometimes referred to as chemo brain, is real, and I think we acknowledge that or see that within the use of chemotherapy, but I do also see it sometimes in men who are taking these other drugs. There is some more confusion, not as significant as perhaps with the chemotherapies. Could that be leading to the falls? I don't have the slightest idea. But I do know that it's common to have men who do report, especially I've heard a lot on enzalutamide, men who do indicate and say that they feel uneasy on their feet. So that is something that is very real.
Yeah. And we have a lot more experience with enzalutamide because it's been on the market for many years in the metastatic state. So I don't know how much of that translates to apalutamide. They are actually different drugs. But all these comments we see, and I'm seeing 2 of them tomorrow in my clinic, that patients who have had falls and also are tired and also are foggy, and and we reduce doses and things, and we do a lot of rehabilitation and PT and things like that.
Stuart Rufus.
Anticipating the question about whether the advance of these drugs will reduce health disparities, and noting the low frequency of black men in the studies, I'm very curious, what insights do we have that contribute to the 110% increase mortality in this population, and therefore what things would we need to do as a medical community and a society to actually impact the health disparity if these drugs were advanced in this population? Or would we be left with similar disparities?
I'll try to field that one. It's a tough one because it's a question that a lot of people are looking at and examining, and it goes not only to treatment but also to the issue of clinical trials, and I think we see that reflected in the data here. There are a lot of different theories as to why men of color don't participate in these trials, and that they also have a more robust or more aggressive disease. And the question comes, is it because they don't seek out or they don't have access to medical care at the same level as perhaps their Caucasian brothers? That's one possibility. Are there genetic differences between black men and white men? That's another very strong possibility. So not only, it's really interesting, not only do we see more aggressive disease on diagnosis, we also see black men being diagnosed at much later stages. Is that an issue of their cancer is more aggressive and advances much more quickly, or is that an access question? We don't know the answer to that. There is also some interesting studies that have come out recently that have shown that within Provenge, which is an immunologic therapy which is approved for prostate cancer, that men do respond black men respond much more positively and get a better overall survival benefit than Caucasian men. And there's also a statistical study done by Dr. Habib that indicates, and I honestly apologize, I don't remember which drug, it could be Enza, but I may be wrong, that black men also do benefit more. So it's an interesting question, it's a real problem, and we really not drill down and really trying to understand, those differences and what we can do as a society to ameliorate those.
That was very well said. So the study he's talking about was recently reported. Dan George and colleagues in North Carolina performed a study with abiraterone in which they looked at both Caucasian ancestry and African American or African descent, and the time to progression was exactly the same. The response rate was actually a little higher in African American and patients that self-identified as black. So there might actually be a biological reason that that there's a higher response rate to these second-generation hormone therapies having to do with androgen signaling and complex biology. But I would say that I don't think that these medicines in particular will by themselves contribute to any disparities unless they don't have access to them, right? So can you afford these drugs, and how do patients get these drugs, and how long do they take them, and are there disparities in that way? So the study I just spoke of gave free drugs, so that made it easy, right? So it's really hard to know in the real world how much disparity comes from sustained access to these medicines. Medicare is complex. So many men are over 65 and have Medicare, and then they have prescription drug coverage, right. And you need 3 degrees to figure it out.
Russell's raised some great points for our policy section. Aaron, can we take your question after the economic analysis, or is it a quick one?
It's sort of quick. I don't think it's very specific. So my psychological benefits from doing something sounds a lot like placebo effect. The idea that which I'm not denying is real, but it sounds like it just doesn't sound like an argument for this therapy. It's just an argument for doing something. And clearly we'd choose something that has the least cost and least side effects. So is there an aspect of that I'm missing above that?
I wasn't suggesting there was, just that when you look at what we heard from patients sitting around waiting to have imaging show the Mets was not surprisingly psychologically tough. And neither the trials nor our economic analysis would in any way include capturing that it's getting rid of that degree of psychological hurt. And so we mention it as a potential other benefit. How much you want to weigh that is, of course, all up to you.
That's great. So I think we're going to move into the kind of presentation of the cost effectiveness analysis. And we welcome Greg from the University of Washington. Thank you for joining us today.
I'll try to hustle through. I think we're getting a little behind on time. My name is Greg Gazauskas. I'm a health economist at the University of Washington at the Choice Institute. My colleague Lotte Stuten, who is not here, helped me with the economic analysis for this project. We do receive at the University of Washington some funding from ICER for various reviews, including this one, but we don't have any conflicts of interest related to prostate cancer to report. Our objective was to estimate the cost effectiveness of anti-androgen therapies to treat non-metastatic castration-resistant prostate cancer using a decision analytic model. I'll go through our methods really quickly. Our population is men diagnosed with NMCRPC with PSA doubling time under 10 months. This is the populations of the SPARTAN and PROSPER trials. Our model was a de novo model. It's a hybrid model. We used elements of partitioned survival model approach, which is using the survival curves reported in the trials to derive the proportion of patients within each of our health states, which I'll get to later. And then also a Markov element where we used real-world evidence to derive transition probabilities for the overall survival problem, since overall survival data is currently immature. Our model was based in the United States with the health sector perspective and a lifetime time horizon, and all of our costs and outcomes were discounted by 3% per year. We used a monthly model cycle since the treatment, the anti-androgen treatment, is fairly consistent. It's a daily oral dose, so that's easy to fit within a monthly cycle, and also the trials reported the outcomes in terms of months. Our primary outcomes were total cost, quality-adjusted life years gained, and incremental cost-effectiveness ratios, which is the cost per quality-adjusted life year gained. And for both anti-androgens, this is going to be versus continued ADT, not versus each other. Really quick here, we've got the interventions, apalutamide, enzalutamide versus continued ADT alone. I'll just note here that all patients are on continued ADT, including the anti-androgen patients, and that they continue continued ADT, and all patients continue until they die. Our model schematic shows that a patient population enters the model in the metastatic metastasis-free survival health state, the green health state. From there, they can either transition to asymptomatic progression, symptomatic progression, or death, and the death being from cancer or from any other cause. Patients who transition to symptomatic progression cannot go back to asymptomatic progression. But underneath, you'll see how we derive the proportion of patients in each health state for each monthly cycle. We use the metastasis-free survival curve, the time to symptomatic progression curve, and overall survival curve that we're modeling, and then the proportion or the area of under the curve for each one of these divides up the proportion of patients who are in each health state for each month. We had to make a number of assumptions for our model where data were lacking. We assumed that the SPARTAN and PROSPER trial populations were similar, which allowed us to make comparisons to a single baseline comparator, the continued ADT arm, and we chose the SPARTAN trial ADT arm as our baseline comparator. And we were able to use the trial reported hazard ratios. And we made this decision because the trial populations were very similar. The metastasis-free survival curves from both trials, and that's for continued ADT, as well as the anti-androgens, were very similar, comparing them. So we felt comfortable using the trial reported hazard ratios versus a single baseline comparator. We assumed that time to symptomatic progression is similar between apalutamide and enzalutamide. enzalutamide in the PROSPER trial. The PROSPER trial did not study time to symptomatic progression, but we felt that this was an important outcome for patients, and so assuming we made the assumption that if time to symptomatic progression were studied in the PROSPER trial, given that metastasis-free survival and the patient characteristics are so similar, we assumed that time to symptomatic progression would also be similar for modeling enzalutamide. We assume that overall survival is modeled using a combination of trial-reported outcomes and real-world 5-year survival data from the Surveillance, Epidemiology, and Results Program, or SEER. And this was to overcome the limitations of overall survival data immaturity. And lastly, instead of modeling trial-reported subsequent therapies, post-progression costs were informed by real-world data on multiple subsequent approved treatments for metastatic castration-resistant prostate cancer. And that's just because the approved therapies in the SPARTAN and PROSPER trials for post-progression treatment didn't include every available option to patients. These are our primary clinical inputs. What I've done is fill in the space underneath each of the survival curves. The green area under the curve is representing time spent in metastasis-free survival. The blue area under the curve is representing asymptomatic progression, and the gray area is representing symptomatic progression. And the thing that stands out immediately is that the time in metastasis-free survival for apalutamide and enzalutamide is approximately 2 years longer than what we see for continued ADT. Now, once patients progress out of the metastasis-free survival, their disease trajectory is fairly similar among the 3 comparators. But that extra 2 years of time spent in the metastasis-free survival is resulting in a 2-year gain in overall survival for the anti-androgens compared to continued ADT. These are our main utility values. This is used to weight each of the time spent in each health state with quality of life estimates. The metastasis-free survival utility of 0.9 came from I believe, a Canadian study of non-metastatic patients, and then the asymptomatic and symptomatic progression utilities came from a UK study of metastatic castration-resistant prostate cancer patients. And as you can see, when patients start the model, they've got a fairly high quality of life of 0.9. This goes down once they go into asymptomatic progression, and then there's a notable drop once patients enter the symptomatic progression health state. Our adverse events of note, I'll just quickly say that for the most part, on most of these, all 3 of the comparators were fairly similar, except that we did model the additional risk of fracture for apalutamide and enzalutamide, as well as increased cardiovascular disease for enzalutamide compared to continued ADT. Our adverse event costs were derived from published sources as well as government sources. For drug cost, we've got fairly similar regimens and very similar wholesale acquisition costs, around $91 per individual capsule or tablet. What we did was we looked at the past 4 quarters of wholesale acquisition cost as well as net price and derived a 29% discount for enzalutamide. We were not able to do a similar calculation for apalutamide since it's still relatively new. Therefore, we assumed the same 29% discount for apalutamide as we had calculated for enzalutamide. This gave us a net price that, once again, is very similar to one another, about $64.50 per pill. Similar net price per month, and I'll just note here that the median duration of therapy was slightly different as reported in the trials, about a 1.5 month difference of time on therapy for enzalutamide. Lastly, here are post-progression treatment costs. These were derived real-world estimates of cost as well as real-world real-world use for the percentage of patients on each one of these agents, except what we did here was we did factor in the proportion of patients who received no treatment as reported in the trials. Approximately 50% of anti-androgen patients did not go on to receive a subsequent therapy, whereas only 25% of continued ADT patients did not go on to get subsequent therapy. So the continued ADT post-progression therapy cost is higher for that reason, because more patients went on to therapy. So these are our primary results. Up top, we've got our cost outcomes. In green is pre-progression drug cost. In blue is post-progression costs. And then in black is our total cost. The anti-androgens have, much higher pre-progression drug cost than continued ADT, but they also have lower post-progression costs. When you put it all together, the anti-androgens have higher total cost compared to continued ADT. Looking below that in our effectiveness outcomes, what you get for that additional cost is an increase in life years in green and an increase in QALYs in blue for both anti-androgens compared to continued ADT. Our incremental results, there was for apalutamide plus ADT versus continued ADT, this resulted in 1.6 incremental QALYs at an additional cost of $108,000 compared to continued ADT for an ICER of $68,000. For enzalutamide plus ADT, we got 1.5 incremental QALYs at an incremental cost of $126,000 and an ICER of $84,000. Now it's tempting to look at these two ICERs and make the judgment that apalutamide is more cost-effective than enzalutamide, but again, we want to stress that this is not head-to-head trial data that we've got, and based on the assumptions that we had to make in the model, I would say that our certainty about the difference between these two ICERs is fairly low. And so hopefully you will focus on the comparison versus continued ADT versus the two anti-androgens together. We did a probabilistic sensitivity analysis where we jointly varied all of our model parameters and over thousands of simulations to see what we got. We found that once we got to a threshold of $100,000 per QALY gained, both apalutamide and enzalutamide were cost-effective, and these results were robust to change in model parameters beyond the $100,000 threshold. We also performed a number of scenario analyses to test results. One was extrapolations of trial-reported overall survival, the immature trial data, instead of our real-world approach that we used based on SEER. We also looked at a 3-state model instead of a 4-state model, and this is in recognition that PROSPER did not study time to symptomatic progression, so we've removed that element of the model out of the equation in both apalutamide and enzalutamide. We looked at alternative parametric curve fits, which is sort of an esoteric modeling thing. We looked at continued ADT comparator based on PROSPER instead of the SPARTAN trial, which the SPARTAN trial was our baseline comparator for continued ADT. We looked at PSA doubling time subgroups. There was reported hazard ratios for less than 10 months PSA doubling time and over 10 months. And so we modeled both of those. And then we also included a modified societal perspective where we included patient and caregiver costs in the analysis. In all of these scenarios, all of the results remained beneath the $150,000 per QALY threshold. And so there was really no material change in the overall summary results that we found in the base case. We had some limitations. The modeled lifetime outcomes are highly dependent on extrapolations of the short-term outcomes observed in the SPARTAN and PROSPER trials. The current lack of evidence for overall survival, And finally, the modeled treatment duration based on trial-reported medians may overestimate the real-world use. So the duration of therapy, if it's not as long in the real world as it was in the trials, then we may be overestimating the cost of anti-androgens. The public comments that we received, the first main one was that the model structure and modeled outcomes should better reflect specific trial-reported outcomes. One of the criticisms related to this was our inclusion of the time to symptomatic progression curve for enzalutamide, which was not studied in the PROSPER trial. But as I showed in the scenario analysis, when we took away that curve, it really didn't have any impact on our results. And then another related critique was that we did not use the time to subsequent treatment, which was reported in both trials. But what we found was that the treatments that the reporting of the time to subsequent treatment was very different between the trials, and so that made it so that we weren't able to really make a good comparison there, and we went back to the real-world outcomes for that. The other comment that we received was that underlying differences in the patient populations of SPARTAN and PROSPER make comparisons between apalutamide and enzalutamide dubious. And yes, there were some underlying differences in the way that the outcomes were defined. There were some, very small differences in patient populations, but mostly the patient populations were very similar, and we saw that the metastasis-free survival curves were highly similar between the two. And I also just want to stress that we did not directly compare the two anti-androgens to each other. So that is important. In summary, more costly but more effective are ICERs versus continued ADT alone for anti-androgen therapy with apalutamide plus ADT or enzalutamide plus ADT are expected to fall within commonly cited thresholds of $50,000 to $150,000 per QALY gained. Our results were robust in our sensitivity and scenario analyses, and our findings were primarily driven by treatment duration, anti-androgen cost, and the cost of post-progression therapy.
Thank you very much. That was an excellent presentation. First, we'll go to questions from the panel. I'll start with one. Were the prices that you used in the model validated by the manufacturer?
Yeah, everything was run by the manufacturers. Okay. There was some disagreement about, how can we use the same discount for apalutamide, but in the absence of anything better, it was, they didn't put up too much of a fight on that.
Okay, I'm just curious. Thank you.
That number doesn't seem right to me. So the cost on the patient end when they bring in their costs and their bills is more like $11,000, $12,000 a month. So I don't know if that just reflects this 29% discount or what.
Good.
I mean, obviously, the price per unit turns out to be an important factor in the calculation of the ICER. So.
It does. And if they were different, then yeah, I think we would. Yep. The fact that they're so similar does really kind of keep the results very close to one another if you were comparing the two to each other.
Right. Well, right. But even if you're comparing them independently,
right,
that becomes an important factor. Greg, do you have any questions?
Thank you. Very, very nice presentation. Another critical assumption is the overall survival. And I'm assuming that you took the point estimate from the clinical trials and assumed that that point estimate was in fact the true survival benefit. But as you pointed out, in both trials, overall survival was not statistically significantly reduced. Mm-hmm. So it just, I just want to underscore that in the absence of real certainty about overall survival, it seems to me that, we don't really know yet what that QALY calculation is. And I wonder if you could comment a little bit more about that. And also the assumption that metastasis-free survival is a good proxy for overall survival.
Well, to the second point first, David mentioned when he was up here that, we need to see that overall survival benefit over a long period of time before we can make any more substantive argument that metastasis-free survival is a good surrogate there. Time will tell. As far as what we used for overall survival, we looked at surveillance, epidemiology, and end results program, the ICER program, which has data from the entire United States, and we based overall survival on the 10-year survival rate for metastatic prostate cancer patients. And so what we did was just take that 10-year rate and derived transition probability, monthly transition probability. We did not, and then, based on that, we create the survival curve that is then applied instead of using the trial-reported overall survival curve in the model. It's obviously not the best thing that we to have, obviously. Overall survival curve with a statistically significant difference and a long follow-up time would be preferable, but we just don't have it, so we had to use the real-world data instead.
Oh, Tim.
So I'm going to want to ask from Russ, because I would not do justice to pronouncing your last name. Did you say $11,000 a month is typically what you're hearing versus what was reported as about $7,000?
Yes.
Okay, so that's about it.
Could I add to that? Again, I'm very limited in the number of men who I have been dealing with who are using apalutamide because it's such a brand new drug and the restrictions on it. But basically, I've been told it's about $12,000, where Xtandi is closer to that $8,000 figure. That's what I'm getting back.
Okay, so I'm hearing about a 50% higher, or even more so than what was used. So let me just maybe summarize at least my take on the evidence report, which was, and maybe it's, and tell me if I'm wrong or being too harsh on it. I saw that there was no statistically significant difference in overall survival, an improvement in a surrogate measure of metastatic-free survival, an improvement in one trial of symptomatic survival, symptomatic progression, but no difference in bone pain, that it does not improve quality of life and leads to increased falls, fractures, and serious ischemic heart disease. Is that correct?
So again, if you buy the meta-analysis, there was a statistically significant improvement in overall survival.
Without correction of a p-value.
I'm not sure. I'm not sure what I'd do to the p-value. It's a meta-analysis. It's the single outcome we're interested in, overall survival. And that said, I can't disagree that we would like better data than this. If you ask me, looking at those data, my best judgment is that overall survival is likely improved. I don't know whether it's improved by as much as that hazard ratio of 0.76, but I will be surprised, substantially surprised, if on longer-term follow-up we don't see some improvement in overall survival given what happened in both trials.
Which I think gets to Greg's comment, which is this model uses the point estimate and assumes that it's 0.76 approximately. Stacy, do you want to say that?
Yeah, so I think the questions around the price assumption for the drugs is really important. I personally was very surprised at the level of discounting that was applied. The 29% seems very large, especially for Medicare and for what I've heard payers indicate that they get as far as rebates are concerned for cancer therapies. I think the other thing that just strikes me is the sensitivity to price increases, which we know from other studies, they go up annually, well above inflation, and that with the expanded indications, there's also usually a very large price increase for treatments. And I think that's important to think about with the threshold analysis, where the price really does sort of move into these different categories.
Thank you.
Eric,
Yeah.
can I just, so just a quick point about the pricing. So I haven't actually done the math, but it's looks about right to me. If the list price is 11 to 12,000 and you take 30% off of that, we have an estimate of around 8,000 as the net price. And that's the way that we have, and we get our data from a consultancy that is able to reverse engineer that, and it's not perfect, but it's in the right ballpark of thinking what the net price is. Why there's this degree of discounting for a cancer drug, which is not usually seen, if we assume that the data are correct, my best guess is because it's an oral medication, and so that at least could be part of the reason that there's a rebate that's of that size. How that will change with the competitive dynamic, obviously going forward, whether there will be price increases or further rebates, is something that we may have a chance to talk about briefly at the end.
So Reem and then Scott, and then I think we need to move into the next piece, please.
Well, thanks for your presentation. I think, so to me, we have limited data, that's the fact. To the best we can estimate, and we have limited number of patients in these trials, so to achieve statistical significance would be surprising. But I think what I'm trying to gather is in the modeling, understandably, when you didn't have the data, you assume that those two medications are similar. We have some evidence to support that they've behaved similarly in affecting the patient's outcome. I think what I'm trying to get to is, from a clinical perspective, is there something that will make you choose to prescribe one medication versus the other that we're not capturing? Because we're making assumptions that they're similar because of the limitation in data. That's what I'm trying to understand. And so far, I don't see anything based on what have been presented that one would be different, better, or worse than the other. But maybe there's something anecdotally that we're not capturing.
So, with the caveat that it's anecdotal, right? So, my sense of the two drugs, having used both of them, is that enzalutamide causes more mental fogginess and fatigue than apalutamide. So, I tend, all things being equal, apalutamide for me would be the better choice. I also give them credit for reporting time to painful, progression. I think that's an important outcome, and so I found the data that they described a little bit more robust between the two. One thing that I know it's sort of not my turn, but I'm going to comment anyway. One thing that I don't quite understand from the data, and maybe y'all can help me, is that so the metastasis-free survival estimate median is about 40 months for both drugs, right? But the time on therapy is about 18 months. That doesn't make sense to me, and it only makes sense if I think that, well, the data are reported early, and there's a lot of censorship because there's a lot of people. It's like sort of front-weighted in that a lot of patients are still on drug at 18 months. And, for me, clinically, I don't change a therapy unless they progress, right? And so I think we have to really think about the time on therapy being closer to the 40 months, because we're not, if they don't progress on median until 40 months, they're going to probably stay on drug until they progress. And I don't know if you could sort of help me on that.
Yeah, it sounds like it would be a good scenario analysis that we could add to the report. Just base the duration of therapy on the time spent in metastasis-free survival, and perhaps at the point of progressing, that's when the post-progression treatment cost. And I think that would be something good to add to the report.
Harold. Oh, just a minute. Sorry, microphone.
This is a question actually both to the experts and to your cost effectiveness analysis. Are there populations for which this is less cost effective, that there's a sense that this will, that there will be additional populations that will be administered these drugs over time where we might find a lower lower cost effectiveness than we're seeing in the scenarios that you looked at today?
I can answer that a bit, which is, again, remember that these drugs have a broad label, including all PSA doubling times. Assuming that disease is much less aggressive with longer PSA doubling times, it would be surprising if the cost effectiveness weren't much worse. And we certainly heard from some experts that there'd be real hesitation to use the drugs at all in people with more indolent disease, even though the label would allow them to be used in those settings. So I think we should be cautious both about the overall efficacy and the cost effectiveness in patients with longer PSA doubling times.
Yes. I don't offer it to patients with long doubling times.
So just to add or ask on to that, is it being utilized as a primary therapy for, let's say, the first PSA doubling after, let's say, radiation or a radical? Or is that a concern of anybody here that this kind of broad labeling is going to lead to that kind of use?
It's complicated. So I would say that the question is, what's the scope of the patient population, right? So it's castration-resistant, so that means that they've been on androgen deprivation already. Who gets androgen deprivation without metastatic disease? It's a subpopulation that, and it's usually the same discussion about doubling time and absolute PSA rise and so forth, and how aggressive their disease we think is going to be. And so it's actually a very small patient population in my practice who meets this criteria: short doubling time, non-metastatic disease. I'm also doing novel imaging that detects metastatic disease sooner, so that changes the patient population. But your question is more that if the label is broad, will a practitioner go, well, hey, if it works here and it works here and it works here, isn't earlier better? Yes, that's a danger, and yes, it can be done. It's being done with abiraterone, and but I can't speak to whether that's. I think it's sort of outside the scope of this, honestly.
Thank you. Wonderful, robust discussion, very thoughtful questions, and I appreciate all the expertise by our panelists. We're now going to move into kind of the public comment and the commenter phase of our work and what the CPAC does. We did not receive any public comment requests from patients or patient groups or clinicians or other stakeholders. We sometimes do, and often do, actually. In this particular case today, we do not have those. So we'll move kind of straightforward into the